All right, I think we're going to go ahead and get started here. I want to welcome everyone. I'm Dan Mendelson. I'm president of Avalere Health, and I'm going to be moderating the panel. We are in a time of very significant disruption in healthcare, and to kind of get things started and to lay a little bit of groundwork, I'd like to kind of walk through some of the common features of the environment that all of the panelists see in the prep that we did, and to kind of distill some of the things that everyone is focusing on. The first is cost pressure. I think it's fair to say that the cost trends that we see right now in the United States are unsustainable, and that is driving a lot of change with respect to finding more efficient ways to deliver care, substitution of labor, generic drugs, biosimilars, a lot of those kinds of if you will, disruptions are being driven by cost pressure, and we're seeing more and more that the cost trends are not abating. With more people insured under the Affordable Care Act, that really adds in a lot of ways to the cost pressures, and so that's something that everyone is focused on. Second is government markets. Government markets have grown very substantially over the last few years. We've done a lot of analytics around what has resulted in growth in insurance markets, for example, and really the only reason why insurance companies have increased market capitalization over the last 5 years has been growth in Medicare Advantage, in Medicaid, and in exchange markets. Exchange markets are difficult markets. Some plans have not done well with them. The Medicare markets are strong. Medicaid is reasonable. But the growth in Medicare, and in addition, the changes in those markets are a disruptor in and of themselves. So government policy is something that we also are all thinking about, and is one of those trends, and new focus on other areas of policy change will drive even more. So for example, there's a lot of discussion around what the administration is going to be talking about with respect to drugs next week, and anticipation that they might be doing something around the pharmaceuticals and Medicare Part B. If they did that, that would cause more disruption and would be things that everyone on this stage is going to be focused on. A third is biomedical innovation, and here you have and there's been a lot of focus on these markets so far at the Institute, the Global Institute so far. And fair to say that there's unbelievable promise. There's a fantastic pipeline, and there's a lot of question about whether the market is going to be able to sustain that growth and a focus there, and how is the capacity to pay going to be coming along. A fourth trend is technology, and here information technology in particular is here. It's coming to healthcare. It's the underpinning of a lot of what's going on in the organizations that are here. I'd say that the algorithm-based care has really progressed quite nicely, and you'll hear a little bit about that actually from virtually everyone on the stage, and it's a major focus of the work right now, as well as one of the trends that we're all responding to. And then finally, and perhaps most important, is a shift in the way that care is paid for, from paying for volume, in other words, like when you go to see the physician, to paying for value in more capitated models. So the government wants to pay a lump sum for breast cancer as opposed to paying for every component of that breast cancer care. And those are some of the trends. So those are 5 trends that I think are kind of in common, that all of the organizations here are facing, and ones that we think are kind of driving a lot of the change. So that's kind of the predicate for disruption. And by the way, there are also theses, or kind of theses for investment, but the disruption is coming in a number of different forms, and I would say kind of 3 in particular that we're going to focus on in the panel today. The first is tools. So there's a new skill set that is required to address a lot of these changes in the environment. So for example, IT sophistication. You need different kinds of people coming into the organization. You need different technology in the organization. So companies that are focused around enabling that change are well positioned. A second is corporate transformation, mergers and acquisitions, Tom. And he's from CVS, you'll meet him in a second. And a lot of the major M&A, as well as some of the smaller M&A, is being driven by cost pressure, government markets, technology, shift from volume to value, and the like. And then finally, I'd say kind of the third area where disruption is coming into play is, for lack of a better term, I'll say white space. In other words, JP Morgan's partnership with Amazon and Berkshire Hathaway. We don't really know exactly what it is. We'll talk about that. But that's the kind of thing that if it came to pass and if it comes together in the right way, it could be truly transformative, but it will sit within a lot of other transformation that's happening among the conventional players. So with that as a little bit of a predicate to get some of the ideas out there, I want to go through and introduce the panel. In fact, have each of the panelists introduce themselves with an initial question. So Marc, let's start with you. I'd be interested in kind of your assessment of, first, this shift from pay for volume to pay for value. And a lot of the clients that we have in the space are very interested in moving to kind of value type metrics, but they're still getting paid predominantly on volume. So you're in kind of that squeeze play, and it'd be great to hear a little bit about some of the ways that you're thinking about that and what you're doing in Intermountain.
So thanks. It's great to be here. I feel I'm having a serious case of inadequacy after listening to the lunch speakers. I thought I had really good stories and stuff until I listened to those folks, and they're, boy, impressive. So at Intermountain, we actually have a long history of working in the payer-provider space. And we've actually been taking risk for quite a long time, although it has really accelerated dramatically in the last couple of years. We think we have about 750,000 lives that we take full risk on. Some within our own health plan and some within other plans, including, for instance, 100,000 Medicaid members for the state of Utah. And what I can tell you is that it's really not easy. And we have had to learn a lot. We've had to invest a lot of money, which I learned means we've lost a lot of money in the past. But now we're actually doing quite well. My concern for the industry as a whole is the folks who are addicted to fee-for-service revenue, which accounts for the vast majority of healthcare systems. Things are getting so hard right now that they're going to have to learn in the face of an urgency or emergency, I'm afraid. They're not learning while their overall financials for their health systems are robust. And I think that's going to be a big problem.
I have a related question. How you have a class-leading healthcare system by any measure, and the entire industry watches Intermountain and admires and tries to replicate. How replicable is the model?
So we'd like to think it's relative. Well, first of all, thank you. And I can take no credit for that. It's really our 39,000 people who've made that happen, all the leaders who came before me. But I'd like to think we're relatively replicable. We have 1,700 employed docs, and we've got 3,500 affiliated docs. We have about a third of our volume comes through our health plan that has 900,000 members in it. But the other 2/3 come from government pay and other sorts of pay. And we now are in a number of different markets within our state, but also now outside the state, including 5 Western states through telehealth. So we'd like to think we're quite replicable.
So one last question for you, and then we'll move on to Tom kind of in this initial round. You announced a very innovative and some might say disruptive activity around generic drugs. You want to tell the group a little bit about that and what your plans are and how that's going?
So first of all, we've announced it as a group. I really want to make sure I give full credit to Rick Gilfillan from Trinity and Laura Kaiser, who's CEO at SSM. They've been my partners in getting this started. But this really comes out of clinical need. It comes from the fact that patients, and they're really paying out of pocket right now, are experiencing both drug shortages as well as exorbitant pricing around some generic drugs. And it's a minority of players who are actually creating a lot of pain. And so together, we are coming together to build a not-for-profit standalone drug company that will address these generic shortages and generic pricing. And we've had more than 70 systems come to us as a group so far. About half of them want to be founding members or are willing to invest $10 million just to sit at the table. And we'll be able to take about 10 of those. And we think we will go to market with about 600 plus hospitals.
How much capital have you raised?
I'm not going to talk about that.
Okay, fine. I will ask questions that people can't answer.
But I
so
will
it's
say
fine.
that the money is no problem.
Right.
I mean,
That's often the
now,
case.
if there are some great philanthropists out there who'd like to help us, we
Right.
do have people who are coming forward who are willing to
Right.
give huge sums of money to help us get started.
And you know, one other thing about this effort, it's disruptive and it's collaborative. Talk a little bit about the collaboration.
Well, look, we're all in this business to help people stay well and help them get better when they're sick. And natural competitors on the delivery side are coming together with mutual interest to do good for the people they serve. And that means both for-profit and not-for-profits coming together to do the right thing. And it has been heartening to see that commonality of purpose.
And then there's one other thing that I'd like you to comment on with respect to the pharma space. When you first announced it, one of the comments that you made that was in the press was particularly interesting to me, where you said that you were going to kind of go stepwise and focus on places of kind of highest critical need, which seemed to me both thoughtful and a bit humble, and kind of acknowledging the fact that this is hard, and to kind of get into a new business. Talk a little bit about how you're prioritizing.
So it really is going to be around where the patients suffer the most. That's where we'll focus. And we're being very close hold around the drugs that we'll choose for obvious reasons, because some of the irrationality that we see in some of the generic space, where people come in, they get rights to a drug, they drive everyone else out by dropping the prices, and then they jack prices up in an irrational way. It's like piracy. So we're not going to telegraph what we're going to do. And again, I do want to emphasize, it's a minority of folks who behave badly who give this space a bad name. My hope is that we would never have to press a pill, but I don't think that's going to happen.
Interesting.
Yeah.
Okay, great. Tom, you've been traveling around the country talking about this merger. You want to say a few words about how you think it might affect patients?
Yeah, I mean, I guess I'll start with the thesis, and it's evident in this entire conference as to what's happening in healthcare, whether it's here or outside the U.S. We have what now, a $3.3+ trillion healthcare budget here in this country, represents 18% or so of GDP. If you follow the projections, it's going to take another 2 or 3% of GDP over the next 5 to 7 years. That's another $250 to $300 billion that can't be invested in other things, be it education, infrastructure projects, and the like. And so more than anything, I think what everyone's looking for in healthcare today is to bend the curve, to stop off a baseline first. Because if you can hold baseline, the savings from holding baseline is huge. That can, as we said, get reinvested, and develop solutions that longer term, and we're talking longer term, can actually then bend baseline down. And that's when you're going to make the real difference in this. And so high level, I mean, we all know where the issues are. There's a lack of connectivity. There are huge issues in transitions in care. There's huge issues around adherence. We've talked about it earlier this morning, and some other panelists have talked about it as well. A drug runs through FDA trials to demonstrate efficacy and get approved. Your adherence rates in those clinical trials are 98+%. That drug gets approved, put onto the open market, and adherence drops below 50%. And why is that? It's because we don't have an ecosystem that supports adherence and compliance and working with patients very directly. There was a discussion this morning about the lack of community and the lack of involvement, and that has a drag-on effect as well to engagement. So how do you leverage existing behavioral patterns and latch onto those to drive behaviors that can drive adherence and drive better compliance? And so the doctors are telling patients what they should do, advising them, giving them the care plan. They leave the doctor's office, and those care plans aren't being followed. So what are the interdependencies that we can help connect and work in a complementary way with primary care to drive a better system and drive a better outcome? So that's really the thesis overall that underlies what we're doing with our business.
How are pharmacies going to change when this merger happens?
So I referenced, behavior, and I think one of the biggest issues we see in healthcare, and we spend a lot of time in our business looking at consumer behaviors, and patients are consumers. And one of the biggest things I've seen in looking at this over the last 3 to 4 years is when you get sick or you have a health incident, you have to create a new behavioral pattern. And it's that creation of a new behavioral pattern that ultimately leads to you not following what needs to happen to fix that. So looking again at behavioral patterns, how do you take advantage of existing behavioral patterns and bring healthcare into those patterns and not force a new pattern to be created? And so if you look, one example we talk about is a patient with diabetes will see their primary care doctor, their treating doctor, 4 to 5 times a year. They'll review the treatment plan, how we're doing our medicines, et cetera. But then we know, because we see it in our data, we see it across the data, that those care plans aren't being followed. Well, that same patient will see their pharmacist 18 to 24 times a year. So how do we better leverage information technology to bring it to those points of engagement? They'll see nurse practitioners on the outside of the physician office, in a high rate as well. So how do we leverage information to get there? So what you'll see in our pharmacies, and I think you'll start seeing pharmacies across the board, because it's not just us. There's a movement to expand scope of practice for pharmacists, to let them practice the higher part of their license, to remove a lot of the administrative work and have pharmacists, technicians, and others do that. So you're freeing up clinical people who can actually work with patients and engage with them when they're ready to engage. You're not picking up the phone and calling them at dinner time or sometime at night when they don't know who you are. They're showing up when they want to engage. So leverage the information and bring it to them then. And then you can add ancillary services and things that complement primary care and redirect them back onto their primary care plan. And that's, again, kind of how things are evolving.
That's a fairly substantial disruption in the system as well as in the activities. Realistically, how Larry Merlo, who your CEO, who's very visionary, has talked about making the customer service in CVS as good or better than Apple, the Apple Store. How long is it going to take you guys to achieve that thing?
Well, no forward-looking statements. But no, I think as you look at the evolution of what
3 months, right?
will happen here, no, but it really will be. You're going to have to make it much more of a community access point for healthcare. And again, it's not a replacement; it's another access point for it. So think about what a healthcare experience should look like, and that's how the locations will start to evolve. It won't be all the locations, but it will be a substantial portion of them as we look at where populations are, where needs are. And I think the other thing that's really important here, and you all know this, healthcare is very local. So there's not going to be a 100% solution across the board on a national basis. You're going to be looking at tailored solutions within communities, community needs, et cetera. And we've learned a lot over the last 5 or so years based on different things that we've looked at the community level that inform how we think about going forward in this new venture.
Great, very good. All right, Mario, speed is actually kind of a nice segue into what you're doing over at Oscar. So I sat on the Coventry Healthcare Board of Directors for 8 years until we sold it to Aetna. And during that time, the number of new insurance companies that competed in our market, 0. Okay, so when Oscar appeared on the scene, many of us who had been in the space for a while said, God, I wonder if that's really going to work. And I'm sure you heard that from a lot of people who have,
all the time.
Yeah, exactly. And so, how do you define success, and why is it working?
Yeah, thanks. So the survival rates, I think, of new insurance companies since the advent of the ACA. We started with the ACA in 2014. I think it's about 1 out of 25. There were about 24 government co-ops that were founded by the government, actually.
Right.
I think all went under.
I think
they all went under, or got gobbled up somewhere. And so we're still here, something we must be doing right. Just a bit about Oscar, I think, first. So we are a full-stack, consumer-driven health insurer. When I started the company in 2012, 2013, I'm a computer scientist originally. I sort of looked at the healthcare system and realized it's way too expensive. I was going through the birth of my first kid at the time, couldn't figure out how this would work. And I also realized that the insurance company is the only one whose business model really benefits when the costs come down. And so these two things together made some sense to me. The only caveat was that nobody likes the insurance company. And nobody pays attention to the insurance company, except for, of course, Intermountain. We always did look at Intermountain and Kaiser and said, if we could be a virtual Intermountain, that'd be an interesting way of getting at some of the same trends that Marc, I think, is getting at. And so what we thought we had to build, and I think did build over the past couple of years now, is an insurance company where first and foremost member engagement is way higher, an order of magnitude higher than for the big insurance companies, where members of Oscar would look at us as the entry points to the healthcare system. And I'll talk about a couple of statistics in a second. And the second piece, the underpinning for that would be we have to build this full stack, meaning on in-house technology. If we outsource claims, outsource medical management, outsource underwriting, it won't work. Because I initially started into this thinking, I can build this like a software project where you deploy APIs, you deploy sort of like real-time access, data access standards and things like that. That isn't the way healthcare works. You know, every single data loads in healthcare is a bulk data load in an SFTP file, as opposed to sort of like an incremental update in real time. You know, that's still the big difference between technology worlds, where you can fast test and iterate quickly and so on, and figure out how things are working, not working, and move on. And really the world of healthcare administration, I should say. I think the healthcare delivery, again, is a bit different there. And so the company we have today is about 250,000 members, a bit above $1 billion in revenues, mostly in the individual markets, which we like because we can go direct to consumers. There's high word of mouth. We can get you with a beautiful welcome package to the Oscar mobile app right away. And as a result, you know, in any given week, about 4% of Oscar members use our telemedicine doctors. And that's in 1 week what the rest of insurance has in about a year or so. About 2/3 of routine conditions like conjunctivitis, pink eye, go through telemedicine now in our case. And it gives us a better ability of understanding and anticipating what is really happening in your healthcare life. Another interesting data point from just last week, in fact, we looked at this. When you look at members of Oscar who go to the emergency room at the end of a 7-day period, you know, so they go to the ER, you look at the 7 days before they go, about 80% of those will have had some touch point with us, whether they talked to the Oscar concierge team, that's how we call our customer service teams, whether they use the app to find a physician, or maybe the ER even, whether they use a telemedicine doctor to talk to the doctor. There is a signal somewhere in their behavior that'll tell us this person might be about to go to the ER. And as we all know, the cost in US healthcare isn't that we're utilizing too much, we just use the system wrong. And so every time we can keep you out of the ER or get you to a better specialist or a PCP, we will all kind of win. So that's
So when you compare your P&L to a standard line insurer, your administrative cost must be lower. Are you paying brokerage? You're paying any brokers?
Yeah, we have, I think, about 25 different sales channels, brokers, government websites, our own website, and things like that. And frankly, that is an interesting market. That's you know, it shows you how complicated this industry is, that insurers make between 2 and 5% of margins, and brokers get paid between 3 and 6% of broker commissions, you know? So must be the only industry that works this way. Right. You make it complicated so you don't have to pay the other guy to explain it away. It's a little strange, but yeah, our P&L.
It's a huge line, and it drives everyone in the insurance industry completely crazy. So it'd be one that I would guess you guys are focused on.
Well, so we work with brokers, and I do think that's like everything else. And this is sort of, I think, take this back to the overall Oscar concepts. Like everything else in US healthcare, if we can somehow build a system that focuses in on fewer partners, fewer hospitals, fewer more engaged providers, fewer lab testers, fewer drugstores even, and fewer brokers, then you can engage that portion in a much deeper way. That's how we like to think about building out the network.
Great, okay. Benjamin, let's talk a little bit about Asia. There has been so much focus on Asia with respect to healthcare over the last couple of years. A combination of high growth, a commitment of governments and really across Asia to improve health insurance status of the individuals, have individuals coming out of poverty in China and elsewhere, and there's really kind of a lot of excitement and enthusiasm on the real estate side, on technology side. You know, many of us who have not spent a lot of time in Asia are spending time over in Asia and trying to think about kind of complementarity. Give us a sense of how you see Asia as a healthcare, different Asian countries as healthcare markets, and how things are changing there.
So I think, excuse me, I feel a bit out of place because in a sense, I think, perhaps if I were to introduce where I come from first. So I come from A*STAR, which is the Agency for Science, Technology and Research in Singapore. We are Singapore's largest not-for-profit research funding agency. But I think what makes us different is that we work primarily with companies. So in a sense, we have actually been an independent observer of developments in the corporate space in Korea, in Japan, China, as well as in different parts of the world. And I think for those of you who are not familiar with Asia, the big difference, I think, is that most Asian countries spend between 4 to 6% of the GDP on healthcare. In Singapore, it's about 4.5%. And while this sounds really small compared to the US, obviously, with 18%, our problem is quite different because many of the East Asian countries, Singapore, Southeast Asian countries, are aging very quickly. The burden of chronic diseases is becoming very rampant. I think in diabetes, you're probably talking about 1 in 5 people in East Asia and places like Singapore having diabetes by 2030. And obviously, there's also the largest growth of the middle class. And therefore, I think what we will project is that Asian countries, East Asian countries, will probably have the fastest growth in terms of healthcare resource consumption in the next 10 years. And even in Singapore, while we are keeping it at 4.5%, we project you'll go to 6% probably in about 5 years' time. 4 to 6% might not seem big, but actually when you look at it in terms of dollar terms, that's a 50% increase in healthcare spending because the base is relatively low. So you're going to see a whole lot of countries that will have as much as 50, 60% increase in health resource spending in the next 5, probably in less than 10 years. So that is actually quite phenomenal when you look at the size of the GDPs combined. So I think when you look at it, I would say that healthcare delivery models will have to change. Many of the populations were largely dependent on state-sponsored, state-provided healthcare services. They've moved into different forms of insurance schemes. I think in Singapore, we've managed to keep healthcare costs relatively low because it's never 100% paid for by the reimburser, whether it's a state or whether it's an insurance company. There's a savings scheme that all Singaporeans have to subscribe to. There's always an out-of-pocket component, which actually varies depending on the scheme that you're in. But I would say that when I look at the disruption, I guess the disruption is not only going to be created by the demographic changes, the healthcare service model, but I think it's also the new players that are moving into the health space. We talk to companies, so we see technology companies like Alibaba and Tencent moving into digital health. Ping An, probably one of the largest insurance companies, access to 30 million health records, is trying to look at disease management at the level of 30 million people. So with the amount of data they are looking at, I think they could actually drive quite big changes. Even the producers of drugs, you have really non-traditional companies. Samsung, mobile phone company, is on track to become the world's largest contract manufacturer for biologics drugs, and with plans to become the largest biosimilar producer. You have companies like Hitachi and Mitsubishi. I mean, traditionally they make engines, they make cars, now moving into cell therapies. So I think what we are seeing is that there is going to be a big disruption also in terms of the new providers of digital health services, immunotherapies, regenerative medicine, and I think they are going to disrupt in terms of being able to perhaps bring products at a cheaper price at different models. I mean, I don't have time to really go through all the details. But
it'd be interesting, though, to hear a little bit more about that relationship between the technology and public health objectives. I mean, how do you see them being successful in achieving on the healthcare goals?
Okay, technology and health. I'd say that one of the reasons why many Asian companies continue to spend relatively low on health is that they've been relatively conservative in terms of adopting new technologies and new trends. I mean, I recall probably about 20 years ago when MRIs were becoming available, there was actually rationing in Singapore in terms of the type of cases that can actually go for an MRI. So I think it is very conservative in terms of how new technologies are implemented. If I were to give an example of precision medicine, I mean, precision medicine is really the in thing now. You do a genomic test to actually determine whether someone will benefit or not benefit from a particular treatment. I think no Ministry of Health, Department of Health is able to answer today, can precision medicine save a health consumer or health reimbursement agency money? We really don't know that. But I think what they have done in a very, very select example in Singapore was a specific link between genetic mutation and Stevens-Johnson syndrome, which is a potentially fatal adverse drug reaction to a drug called carbamazepine, prescribed for epilepsy. And I think in Singapore, we are probably one of the few countries where we can actually reimburse that genetic test for a doctor before a doctor prescribes this drug. But to actually get to that point, it was actually almost 1.5 to 2 years of health economic studies, getting all the data just on one test. So in a sense, I think it reflects partly the conservatism. We don't run in just because it's available. We don't go for 750 cancer screening panels, but to very selectively only choose when something comes at the right value. I think value-based reimbursement was talked about before we actually move in. So I'd say that it's a part of regulating the introduction of technology by ensuring that it comes across at the right cost effectiveness and the right value before implementation.
So it's very interesting, and I think you fit right into a lot of the themes. You know, even though the needs of the system are different, I think a lot of the issues that you're focused on are the same ones we are. Sue, you're in a really interesting position. You should say a little bit about what you do and kind of this concept of what is essentially an incubator within a larger company. And I'm interested in hearing a little bit about how you think about disruption relative to the technologies that emerge that you see.
So first, one of these things is not like the other.
I think we're all not like the others. That's why it's an interesting discussion, right?
Yeah, and I can't sing worth my life, but I had to do that just for a second. So first, you asked me to just talk a little bit about what we do. And I'm Chief Innovation Officer at GE and CEO of Business Innovations. And what we do within Business Innovations is we've got a ventures group which does equity investing. We have the new business creation group, which is what he was referring to as it relates to actually creating companies from scratch. And we've done about 7 of those in the last 3 years. I'll talk about that just a little bit. And then we have the licensing group also, which is all around value creation using 58,000 of our patents and technology, and a number of other things overall. But you know, part of what is happening in a company like a GE, as an example, is disruption is pretty rampant across all industries. There's no doubt. And the pace of change, and we all know this, the pace of change will never be as slow as it is today. Think about that, right? And so when you know that all of the disruption that's been talked about already is happening, what is the role of technology and how do you go about thinking about how that plays in the world of healthcare? And I'll give it a little bit of a frame of it's not only in the healthcare space, only because I'm also in the energy space and the aviation space, et cetera, within GE. And what we've seen is technology is super, super important regardless of what industry you're in. It's part of sort of the foundation. What's different is today, because of the digitization that has happened in every single industry, and particularly now in healthcare, business models are just as important. Oscar, prime example of really disrupting really the health insurance space and the engagement space, if you'd like, because you've brought a new business model to the equation. And you're going to see that more and more, I think, in the healthcare space overall. In addition to that, and you talked about non-traditional partners really coming into the equation, the Hitachis and the Samsungs and so forth and so on. The other part of technology adoption is that because the pace of change is so fast, you have to partner. There is no way not to partner. You know, it used to be a company like GE, because they're so big, we're in 180 countries, you know, you name the industry, we were probably in it. It was very easy to be able to say, we're not only going to create the technology, we're going to develop it, we're going to launch it, we're going to go out to, you know, whichever country it is, because we had that kind of scale. The reality is, with as fast as things are moving, and because the technology conversion is so fast, you can't do that anymore. You have to do it a different way. So I think the whole dynamic is really changing overall as it relates to how we're sort of approaching healthcare. A couple of things, and then I'll end, and that is, as you think about a company like ours, we're not only a technology provider in healthcare, we're also a large self-insured employer that covers over 500,000 lives. So we have to be very cognizant of the cost of healthcare and what that means in terms of competitiveness, not only in the US, but worldwide. And so we are very, very, we stay very close to the trends and what we might do in terms of different business models there.
So as an employer, what is the disruption that you would most like to see?
Drug pricing come down. I think that everybody would say the same thing, right? I mean, hepatitis C, my goodness, I mean, it'll bankrupt any company if we're not careful, right? And you talked about biosimilars, and thank goodness we've got some biosimilars coming in that space. But the reality is the cost of particularly specialty drugs are just so high. Now, you know, you understand the development cost that has to go into it. But the reality is to be able to access it as even a large self-insured employer with good profits, it's just remarkable.
Okay. Challenging. Excellent. Okay. We have about 25 minutes left. We'll go into 10 minutes of kind of lightning round, short answers to questions, and then we're going to open it up for the last 15 minutes to your questions and comments, because I'm sure that we've offended at least somebody in the room who's ready to ask a question, if not everyone in the room, given the diversity of the panel, which I think is great. I want to actually ask kind of all of the panelists to identify the disruption that they think is most promising aside from their own company. You know, so you can't say, you know, pharmacies retooling themselves to. I guess you've got a pretty diverse portfolio, but just, you know, no, exactly, no. You have to give something interesting. But you know, what do you think is really interesting and has a lot of potential to disrupt, improve quality, reduce cost? Who wants to go first?
We're in like a couple hundred businesses, so it's hard to say.
I think
what I love.
I'll loosen the stricture a little bit. You know,
so
try not to be self-promotional.
No. I love the fact that you can see people with a high school education who are serving as navigators to help keep people well. That the barriers to entry to being a healthcare provider who really makes a difference have gone way down, and that gives me hope for those people in their communities as well as the people they serve. I love that.
Okay, so personal care services and Medicaid's a great example of that, where, you know, essentially you bring in what is in essence a lesser skilled concierge to help with you know, the issues of living.
And the only thing I'd challenge is the lesser skilled part, because done right, you generally get the people from those communities who have the cultural competence to understand the members/patients who they're taking care of. And so they may be lesser skilled in a traditional way in terms of what degrees they have and letters after their name, but they may be much more skilled in terms of navigating the sociologic features.
Right. Yep, fair point.
I'll
go
go
down
next.
the line?
Yeah, I
Okay.
think, well, two things. First, at a very high level is what I think is a very healthy trend that is clearly accelerating is competitors working together. So, you know, this sort of old line thinking of, well, you're my competitor, we can't talk, we can't work in an area where we don't necessarily compete and we can actually move the ball forward. I think you're seeing any number of different initiatives across healthcare in particular where that sort of old thinking is being replaced by, I have this capability that if I can latch it with your capability over here, we can truly accelerate change and drive new solutions. And I think that's very healthy. And I think the other thing that's very healthy is a very clear recognition of how local healthcare is and the need to provide local solutions to that, because what may work in where I'm from, Short Hills, New Jersey, will not work necessarily in Utah. So having a sensitivity to that and understanding what those cultural norms are, behavioral norms are, and driving to solve for those, I think, is a healthy trend as well.
You spend a lot of time, you testify in a lot of different state capitals. What do you see in Medicaid right now?
Well, I mean, what's very clear is the attention that it has of the chief executive of each and every state. Those Medicaid budgets have grown to be almost 1/3 of the state budgets, and so how that money is spent, where it goes, not only in terms of the existing spend, but what's going to happen to funding downstream or down the line is hugely important. And so driving new solutions, getting better value for that, moving to lower cost sites of care. There was reference to emergency rooms, moving folks out of the emergency room as a primary care center, which it is for a lot of folks today, into true primary care and the savings that can offer. So when the budget pressures come, you've created that relief valve. I think a lot of states are focused on that.
All right, Mario, what do you like aside from Oscar?
So I would say disruptive trends, individualization of the economy. I think so many things that are wrong in the US healthcare system go back to the fact that there is ultimately no individualized competitive pressure on the value chains. When you plot physicians in a given city, we do this all the time, on an axis of efficiency versus effectiveness, whether people like the doctor or have good clinical outcomes, there is never a correlation. There's no market mechanism that forces sort of like cost in line with quality in healthcare anywhere. And I actually do think that the more the economy itself individualizes, the more you have freelancers and freelance designers and coders and whatever, and the more they will buy individualized healthcare, the more all the people on the stage here can build more individualized products for them that will put that pressure on the system. I think that's going to be very, very powerful. I think the second thing perhaps I would say is I actually like the fact Oscar might be the only company that got created by more regulation or less regulation. And so I actually like the kind of regulatory innovation in a sense we've had to endure sometimes in the last 15 years. Medicare Advantage in a sense was a new regulatory framework, unleashed lots of creativity in the markets. That was a good thing, and I think it has to be smartly done, everything else, but more regulatory innovation in a sense can be powerful. And the final one, I'll go totally on a limb, is games. I think people have created addictive and sort of like interesting games that engage people. Too little of that has made its way into a rather boring industry like healthcare that you'd rather stay away from if you're sort of like users generally healthy, and I think we can import some of that into healthcare to get people engaged more.
Maybe for fitness or mental acuity
even
or whatever.
And drug adherence and almost anything in there, stable care plans and making sure you go back to the doctor after you left the ER in a certain time period and things like that.
You know, I want to actually get back to something you said in the beginning, which is really important, which is standardization of electronic medical records. And so in the beginning you said that, you know, it was more complicated because you realized that things weren't standardized. And now in the things you find interesting, it's like if there were standardization and things were more plug and play. Do you have ideas about how to fix it?
Yeah, I would. So
it's going to be like Adam Bowler, who after he had a phenomenal success with Landmark, is now going to be running CMI, right?
Yeah, exactly right. He's the right guy for that job. That's an amazing person, exactly. So I think one thing I would say is the cycle time in healthcare administration has got to increase. Again, this sort of like bulk data loads every quarter. You know, the way we get roster is in the weeds, but the way we get the files of all the physicians who work for particular hospitals from the hospital partners we have is once a quarter you get an updated file, and about 30% of the phone numbers are wrong. And it's the case because these files are built to facilitate payments, nothing else, not physician discovery, not sort of like getting the right person at the right time for the right disease and things like that. So in every organization healthcare has got to move towards how can I go towards real-time data updates? What would that do to my business? What would that enable in the business? And how could I work differently with the partners I have? That would be an important interoperability thing. And then you can level up what we right now talk about in terms of data interoperability towards almost like workflow interoperability. And you can, when you buy the plane ticket right now, you can also buy right away a rental car, and you can book a theater or whatever, stuff like that, because there's standardized workflow API access points. That is just not the case in healthcare, and we got to somehow get there. And what will create that again is the individualization of the access and of the economy.
Great, bring us there. I'm with you. Benjamin, at A-Star, what do you see that is particularly compelling?
No, I think it's trying to keep sick patients out of the hospital and in the community and at home. And I think that is actually very reachable with the digital technologies, the wearables, the monitoring systems that you have today.
Yeah.
But I guess it's the change in the mindset of the patient, the caregiver, to actually move into that model. Because I think when you look at where most of the health resources are going, it is in acute hospital care. It is in end-of-life care for patients with terminal diseases and cancer. So I think it is to actually be able to monitor and to manage such patients at home, such that you actually have a less demand on the healthcare system.
We see a lot of that right now, and I agree with you. I think there's tremendous potential there. So, also the use of analytics in understanding patient experience. We've developed analytics to facilitate post-acute care transfers. So when the patient is leaving the hospital, how do you optimize around cost and quality to make sure that the experience is best and results in fewer readmissions to the hospital and stuff like that? Do you also, so in some of my travels in China recently, I've also been seeing a lot of robotics that are being deployed as, in substitute for healthcare practitioners. Have you seen those technologies, and do you think they're going to work?
I think it's still too early for medical robotics. Many of them actually help in the more manual and physical tasks in a ward. Loading a patient onto a bed, transferring a patient from point A to point B, dispensing drugs. But I think it's probably a little bit gimmicky
early
at this
on the
point in
curve.
time. And I don't think we actually will move to the right price point of having a robot replace physical staff, physical work in a hospital environment.
Okay.
I'm not sure.
Good.
I'm not sure.
Sue, what do you see? What do you like?
Well, I still will come back to digitization, and I will say the following, and think about it in the following trends, and that is, because everything is being digitized, you have the capabilities now to really change from centralized to distributed, right? So hospital to retail to home to wherever what used to be the patient is now the consumer. It's the same individual. So that's major trend, right? Major disruption. Two is this notion of CapEx to OpEx, where you used to buy, provider systems would buy MRI machines as an example. Now it's teleradiology. And they can consume it by a unit, just like you do with Uber. You don't have to buy the car, you actually buy the ride. And then the other underpinning trend there is the notion of going from dumb and static devices to smart and connected devices. All the wearables and everything in the hospital now being connected, being able to be put back into the EMR, and really being able to converge all this data. And when you heard it actually touched on all the way across, with everything is underpinned now with this thought of patient experience, because in our world, everything with our smartphones is all about tap and swipe, and you have that convenience, that experience that you just expect. Why can't we get that in healthcare? And with digitization, that type of engagement and that type of ease should be that available.
Great. Okay, we have about 10 minutes left for questions. So what's on your minds? So you're not going to make me ask these guys how to solve the opioids crisis or anything. That's going to be the next question. Yeah.
On the panel on disruption, I think there's only been one mention of Amazon, and I think it was you, Dan. So I'm curious if others have thoughts about to what degree, and I think perhaps most interestingly, if you're not at all concerned in your particular area about whatever Amazon may or may not do, individually or as part of the partnership that Dan mentioned.
Great. Actually, let me reframe Raul's question a little bit. Is it real? Is it going to happen? What is it going to do? So who wants to take it?
I'd love to take a crack at it, and then I'll.
Excellent.
And as we've really looked at Amazon, what does Bezos say all the time? Your margin is my opportunity. And it's very clear, particularly with the strength of supply chain, that going after industries where, in fact, in the healthcare area, where you can supply the kind of non-durable goods, as an example, or some of the other goods like dental supplies, where now you're eliminating the middleman. I think Amazon is going to be real, and I think it's going to happen more and more because marketplaces in every industry are occurring, and Amazon is extraordinarily well placed. The second area that people talk about all the time is they have more psychographic data on any one of us because of a digital twin than we could even know, right? And you've also heard the notion of zip code is more important than your genetic code these days. So you start to think about that power that Amazon has, not to mention everything they've got in our houses, right? And you sit back and say, if in fact we start to consent to allow our data to be mixed in with the data they already have around us, our health data, the power they've got is pretty remarkable. How they monetize it will be interesting. And I haven't totally figured that part out.
Tom, what's your take?
Well, just a
Not
few
to put
things.
you on the spot or anything.
No, but
You're in retail. Know something about the subject.
there are a few things. First off, it's a $3.2 trillion marketplace. So there's room for lots of new solutions. Things need to be disrupted. I think there are some core questions around personal versus impersonal, how personal healthcare is versus how impersonal some other industries may be, and what impact that has as well. How local healthcare is and how people access local healthcare with providers they trust and folks they interact with as well. So those are all questions I think that are out there. They're real. You never underestimate any competitor, but you also need to be focused on your knitting and make sure you're driving value. And if you're driving value, you'll have solutions the marketplace will take.
Anyone else? Yeah.
Just one final thing. Whether they're real or not, healthcare is too expensive, quality's not good enough, access is terrible in a lot of places, and our segment of the GDP is gigantic, and the crosshairs are on us now, so something's going to change. And the good thing is I actually believe healthcare is going to be better and more affordable for Americans going forward. The question is who gets to play, and I do think it's going to be a mixed model. There be companies like Amazon, but there's still going to need to be some people who take care of folks in ICUs when they get hit by a car or something like that. So it's not that simple. But I'm extraordinarily optimistic. One of the challenges for all of us is how self-protective are we going to be about our jobs and the structures we work in, and how flexible are we going to be in order to serve others who actually really need us? And I think that the ability to innovate or self-disrupt in the pursuit of both economic and social good is going to be a crucial feature for those who are going to be successful.
Okay, Mario?
I think it's generally a great thing that they're coming in. I think it's interesting to me that when you look at the percent of Americans covered by health insurance that have deductibles over $1,000, and you go a mere 10 years back, that was basically close to zero. Now it's 50%. So there's some kind of safety valve blowing out in healthcare where the cost is just massively shifting towards the end consumer, and whatever person and entity tries to do something about that, I think is commendable. I think personally, experience or sort of a question I have as well is on the personal side. When you try to talk to Amazon and get a real person on the phone or in the chats, they'd much rather take your package back rather than ever talk to you once. That's not how healthcare works. I mean, we know that if we show you the pictures of the people on your Oscar concierge team, and messaging goes up by 20-25% just because it's a picture of a person you can relate to, and so somehow they're going to have to weave that in to whatever they do, and then it can be powerful.
Anything?
Nothing on Amazon?
I will, because I'm the only one, I have a very different opinion of this, I think, from everybody else on the panel, so I'm just going to insert a little bit of non-moderator comment here. There have been a whole array of tech companies that have positioned around healthcare and either failed or dropped out of the market. And I think that I go into it with a little bit of caution. I see the power of it as well, but actually doing things is hard and execution is hard. And then in addition, there are a whole bunch of people up in Washington, D.C. who think that if they get in, new regulatory frameworks have to be imposed to deal with issues of privacy, which Sue alluded to as a powerful tool, but it's also something that Americans really worry about. So I'd just kind of insert a little bit of a cautionary note there. We have a lot of hands up, so yeah, I'll defer to the microphone.
How do you do? So disruption typically leads to dislocation and disintermediation. And I expect we'll see a lot of that throughout the entire healthcare ecosystem. As such, a financial risk gets transferred in novel and and perhaps unintended ways. How do each of you see the redistribution of risk, and how are you trying to hedge that risk? And then with the caveat being, the consumer, it shouldn't all be shunted to that consumer, right? Because we're seeing levels of bankruptcy driven out of healthcare bills. It's I think it's the first or second leading cause of individual bankruptcy in the U.S. And a new term has been introduced into the clinical community, financial toxicity, where you're actually seeing patients now avoiding care out of concerns around that. So can each of you look at it through your own lens of how you envision managing redistribution of financial risk?
Okay, so that we get through more questions, I'm going to say one response per question, and then we're going to kind of run the table. So who wants to take this one?
I'll take it because I think the issue of prescription drug pricing was raised as well, and that's where people are seeing that hit them, pretty much every day. Your pharmacy benefit is the most used benefit, and in a high deductible health plan, you're going to run through your deductible much more quickly because of pharmacy than anything else. So what you have to do, and what we've been doing, and I think others have been doing as well, is first get that lowest net price possible available for each drug, but also the advent of high deductible health plans has pushed it to the consumer. The tools to help them manage that have not followed. And so tools like making it available at the doctor's office, that when the doctor wants to prescribe you, drug A, she can see that actually drug A is going to cost you $300 because you're in a high deductible health plan, because she has in front of you your benefit design, where you are in your deductible, and what the therapeutic alternatives are within your plan to say, rather than that $300, there's a drug that's just as good as that $300 drug that will cost you $15. And then if it doesn't happen in the doctor's office, making that technology and capability available at the pharmacy counter. So your pharmacist can do that. And then when all else fails, make it available on the phone through an app. So you as a patient have better control of what you can do. And you can start that in pharmacy, and you can see how, when you bring that transparency across healthcare, you as the consumer who's owning first dollar more and more, you're going to control a lot more of where it's done, and you're going to drive a lot of change because of that.
Okay. Next question. I'll try to get through a few of them quickly because I think we have 3 minutes left.
So I think a lot of the conversation has been about technology disruption. I'm from Silicon Valley, but I'm actually more interested in financial disruption, given that there's starting to be pretty clear evidence that certain food producers, processed meats, high carbohydrate, other sugar producers, soft drink producers are directly causing death, cancer, heart disease, diabetes. What about using financial disruption to do a combination of short selling and class action lawsuits against those folks?
Wow.
Wow.
Great idea. Next question.
That's a good response.
There are a number of tax approaches that are diving into that, not only here but also in other countries. So it's an interesting point. Yeah.
So maybe pulling together a couple concepts that you guys have talked about. So one of the ways to get out of some of the challenges relating to the cost of healthcare is to focus more on prevention and changing our R&D models to focus on that. And I don't mean just like general wellness. I mean actually knowing who's at risk for or susceptible to a specific disease and then preventing them from getting that, which helps. But then it also sort of ties to Amazon, Sue, and what you were saying, that they maybe know more about us than anybody else, and they may be a player who could actually in some ways help to anticipate what diseases you're likely to get based on what you're seeing as your spending patterns, and you start combining that with sensor and tracking info, and you see somebody's not walking as much or whatever, and you start to get a holistic picture that allows you to really disrupt the whole model and keep people healthy. And so I'm curious what you guys think about that.
I figured Mark would. He's
So
the furthest along.
Yeah, so we're in the trenches, right? So we have 7 million touches a year with patients across our system. Intermountain is and has been a model system and is very successful. In the midst of our success, we have now carved out our community, our primary care business, and we're calling it community-based care. And we are reorienting it as we speak to be a purely preventative sort of organization. Now, that's going to take probably 5 or 6 years for us to get through that. It's been fascinating to watch who among the providers actually want to play and who don't. And I'm shocked and thrilled at the number who actually really want to actually change their practices to keep people well. What becomes interesting then is what percentage of your business has to be at risk and capitated in order for that to be viable. We're sitting at about 1/3 of our total volume is associated with risk. And the conversation we're having internally is, how do we evolve that, and what percentage is the right percentage in this current era? So it is really complicated, but the providers want to play.
Okay, we have time for one last question. Did you have a question? You look like you were burning to have a question. Yeah, no, maybe.
Just been burning to be at this panel.
You get to have the last question.
It's in about the opiate epidemic.
Excellent.
Kind of, sort of. I saw Thomas's panel in New York and on the summit regarding that. What is the biggest, you talk about digital, deployment and the pain points. Where do you see it using digital, mobile applications? What's the hardest thing to deploy that to big numbers? You've got 500,000 people that this specific disease. What's the biggest pain point, and what makes it work? What doesn't make it work?
Who would like to have the last word on the panel? It's either going to be Sue or Mario, I think.
Mario, let's do it together. I'll do it real quick. And it's cultural. I'll be frank. It's not something you change overnight. People know there's tap and swipe ease on your mobile phone, but you still have to learn what that means. And this whole cultural adoption, particularly demographically separated by age, it's kind of interesting, right? We have a whole bunch of folks who want to adopt those, and we've created a whole bunch of tools, like Marc was talking about and Tom were talking about, to enable them to engage and being able to know transparently where better to engage and how to manage cost of health. My generation, let me put it that way, yours too, that's just not as easy. They're not as interested.
Mario,
Sorry,
last
Mario.
word.
Something in addition. Oh, yeah.
Okay.
We're on the table.
Beyond culture, it's also how clean the data is. Because I think at the end of the day, you have to look at how linking and validating the inputs against the outputs. And most patient records are too dirty to actually give you very reliable prediction.
Yeah, exactly. Yeah.
So there is a technological perspective as well.
Yeah, there's there's a fundamental infrastructure question again. My favorite example always is if we try to do what's the reverse of what Uber does, where maybe you pay less in a situation where there's many cabs on the streets, whatever, things like that, dynamic pricing, like that. You couldn't do it in healthcare because the claims formats that's used in the US doesn't have a time of day on the claim. So that is a very fundamental limitation. We got to get over. These pipes have to get rebuilt. But the second thing to me, I go back to the individualization of the economy. When your employer bought you a phone, you had a ugly feature phone in your hands. And when you as an individual demanded a great phone and were going to go out and buy it yourself, you started getting the iPhone. To me, fundamentally, unless individuals can make more choices, stay with insurance companies, hospitals longer, none of this preventative stuff and so on really will have a business model. If the insurance companies change you on average every 2 to 3 years or so, they will not be able to invest in your long-term health. And that's one of the big things we got to break through.
Okay. Please join me in thanking this outstanding panel.